Hello, and welcome to today's VMR. It's a very special one. We have a very special guest. It will be about clinical reasoning, and we have a world expert with us today, Dr. Daniel Restrepo, and he's shaking his head, but it is true. So glad we have you today, and welcome everyone that joins us today. My name is Sammy. I'm one of the CP Solvers team members and the last year med student from the University of Graz in Austria, currently doing a rotation in Michigan. And I'm so hyped for this session and can't wait. But before we go on with all of that, I just wanted to take a minute or two to talk about what's going on across all around the world right now. And we from the CP Solvers, especially Maria and Madalena and Sukriti, came up with a great idea to establish a fundraiser for this week's VMRs. So we will share some links and consider donating, but I think I will hand the mic to Maria to tell us more about that.
Thank you, Sammy, and thank you everyone for giving me this opening. In CP Solvers, we're very proud of this global community we've created. That means that we get to share a lot of great news from all over the world and share happiness from all corners of the world. But that also means that when something bad and a tragedy happens across the world, we also get to feel it. So after we've heard all of the news of the floods happening in Pakistan, almost 500,000 people have been displaced. A lot of people have lost their homes. And Pakistan for us really hits home. We have a couple of our facilitators, just like Rabi and Ravi. They both have family ties in Pakistan. We do have a big community of people joining in from Pakistan, and we felt compelled to shine a little bit of light and awareness to this event happening. And we do it the way we know how to share things with others. So we try to do it centering around the case and having awesome people discuss a case. That always brings happiness to us. And today and for the rest of the week, we'll be doing VMRs dedicated to raising awareness for Pakistan and raising funds for Pakistan. We've created a fundraiser link in Doctors Without Borders. It is for us the easiest way to fundraise because all funds go directly to them. So even small donations they still matter for Doctors Without Borders. And if you want to donate a little bit of your money, you can do it through the fund. You can also donate through information, sharing the links with others, sharing with us, sharing through VMR, through Twitter, through social media, through YouTube. And we'll try to fundraise. We'll let everybody know constant updates about all of the VMRs. So hopefully we'll reach our target. And we do have another special event. Dania is a doctor from Pakistan who's been a member of the VMR team for a while. So she's going to be joining us on Friday with Rabi and Reza for a special case. So I'll be sharing the link here and we'll see. The target is 5K. We did a fundraiser before a couple months ago. Our first fundraiser was for raising awareness and funds for Doctors Without Borders, specifically for Ukraine. Our target was also 5K, but we managed to reach like 7,400, if I'm not mistaken. So hopefully this week will also show us the power of community and the power the CP Solvers community has around the world. So yeah, I'll stay around and answer a couple of questions if you have them through the chat. And thank you so much, Sammy and Dr. Restrepo, for giving me this little moment of your time.
Oh, Maria, thank you so much. That were so kind words. And I think we can all make a small impact, and just also every amount counts, and really consider donating. It's really for a good cause. So going to the next step, I just want to shortly introduce Dr. Restrepo. I don't think he needs too much introduction, but he is a general internist and hospitalist in the Department of Medicine and a member of the core educator faculty and the associate program director for POCUS for the internal medicine residency program in the Massachusetts General Hospital in Boston. And in his interests are especially clinical reasoning and point of care ultrasound. And yeah, I also want you to ask Dr. Restrepo, maybe share something outside of medicine that you enjoy and what you like most about diagnostic reasoning.
So thank you so much for the introduction, Maria, and to the whole team that's kind of working on this fundraiser. That's absolutely amazing. You can count with my support, and thank you for the work that you're doing. I'm super excited to be back. Glad I didn't burn any bridges last time I did one of these, and so that you guys are allowing me back in the building, which makes me very happy. I will tweak what you just said, and it is a little bit about medicine, but it's something that was really special that happened to me this last week. I actually got to go back to my medical school in Florida, and for 3 days, I actually got to spend time with my mentor, the guy that you're probably going to hear talking through me. He's the person that I kind of parrot when I teach and I talk and I take care of patients. And I got to round with him, and I got to sort of spend time on the wards with him, and just, actively seek out mentors, and really, to every learner that's on the call, like, maintain those relationships with them. He came to my wedding. It's sort of just, it's a really beautiful thing to have mentorship. So that's just wanted to reflect on that for a second. And what do I love about diagnostic reason? It's like it's why I did internal medicine. It's kind of like, it's just figuring out, it's the puzzle, it's the mystery, it's the recognizing of patterns and kind of making diagnoses on the spot. That was like what was internal medicine for me. And that was who I really wanted to be as a doctor. And I sometimes get to do that, which is really cool.
That sounds great. And for those who don't know, you definitely have to check out Dr. Restrepo's last New England CPC case. I'll post a link in the chat. It was also a very good one, and with a special focus on clinical reasoning and framing and different Venn diagrams. But yeah, I would like to introduce the rest of the team. Deborah, Shema, and Mukund. Maybe Deborah, start with you.
Hi, I'm Deborah. I'm a med student in Argentina. I'll be graduating next year, and I'll be the case presenter today. Excited for the section. Shema.
Hello, everyone. I'm Shema, and I'm a medical student from Berlin in Germany, and also very excited for the session with Dr. Restrepo. And I can also just recall what Sammy said with the case about cystic lung lesions. It blew my mind away. Mukund?
Yeah, hey everyone, I'm Mukund. I'm a second-year medical student in San Francisco. It's nice to see everyone.
All right, then without further ado, can we get the whiteboard up, and Deborah, kick us off.
So it is the fifth complaint. It's a 42-year-old male with shorts of breath. The patient for the HPI said that he's presented for the 3 months and is worse with extension and relieved with rest, and worse with laying flat, is associated with dry cough, and he denies chest pain, fever, chills, and weight loss.
Okay, so we have a relatively, each year that goes by, I'm going to say this is a pretty relatively young person coming in with subacute to early chronic exertional dyspnea. Now we're given a little bit of information that rest is a relieving factor and that exertion is an aggravating factor, which in the case of breathlessness is pretty common. I don't think it differentiates that much as far as anytime you're going to kind of put your cardiopulmonary system under the stress of exercise, it's probably going to worsen most cardiopulmonary pathology or even anemia. I'm intrigued by the worst with laying flat. Orthopnea has a modest likelihood ratio. It increases the chances that the breathlessness is due to kind of elevated left-sided pressures, so an elevated pulmonary capillary wedge pressure. So that's something that kicks around. If you have anybody that's sort of breathless enough, laying flat will also just make things work because your diaphragm doesn't have the help of gravity. So that's one thing I'm kicking around. And then the dry cough, you know, does it localize the problem to the lungs? Not necessarily. I mean, it does increase makes me think about things that do present insidiously with both cough and exertional dyspnea. This could be things like the like interstitial lung disease, or again, we're back to that kind of decompensated heart failure. So don't be fooled. Pulmonary edema very often causes a cough. But then we also need to think of other kind of primary lung diseases. Common things are common. You know, it's going to be crucial, like something like asthma. It's going to be crucial to obtain a history of atopic lung disease, a prior history of asthma, right? New onset asthma in a 42-year-old starts to be a little bit suspect. As folks age, you should question that diagnosis even more. So history of atopy, prior history of asthma, his smoking history, his medical history, obviously medications, lots of things are going to come that are going to be really informative, I think, in the next few aliquots. But again, the only other thing to think about is anemia. So the big three causes of breathlessness, dyspnea, of dyspnea, things like heart disease, lung disease, anemia, and then there's like much more rare things that we can address once we really take those three off of the table. I don't want to start kind of climbing down or climbing up the pyramid of dyspnea in this case. Anemia would be a little bit weird with the dry cough and the orthopnea. It's usually primarily just exertional dyspnea or fatigue or intolerance. Oftentimes people will kind of describe whooshing sounds in their heads, or they'll have the symptoms that led to blood loss or the anemia. Maybe I'll stop there, see if anybody else has any thoughts.
Wow, that was just brilliant. Thank you for that. I have just a question. Does the lack of obvious signs of inflammation, for example, lack of fever, chills, or weight loss, does it help you in any way with your reasoning, or doesn't it change too much?
I think that I've just seen too many like horrific inflammatory and malignant causes of disease without those sort of canonical findings of constitutional symptoms, that it doesn't have enough diagnostic resolution or diagnostic resolving power for me to completely write those things off. Obviously, the tempo itself already argues against most kind of traditional bacterial infections, as pneumonias are common causes of breathlessness. But you got to think about, you know, there's more atypical infections, in which cases his epi, kind of who he is as a substrate and his problem representation, is going to play a role in there. I don't think upfront the lack of fevers and the lack of weight loss like nail it for me. I've still seen plenty of inflammatory and malignant conditions that don't have those findings.
That is just such a good point. Thank you, Deborah.
Oh, great discussion. So going for the past medical history, the patient had known past medical history, no medication, no history of alcohol, smoking, or drug abuse, denying any allergies.
And no prior like atopy, like hay fever, allergic rhinitis, eczema, anything like that.
No, nothing. And
then
going.
Sorry, go ahead.
No, you can.
No. So I guess the one thing, and we're going to hear about his family. He's young enough that family history still very much matters. So I am waiting to hear about this. The other thing is, you know, we've discussed his health-related behaviors, and I know that Deborah is going to give me a wonderful social history beyond his use history, right? Because a lot of kind of what people do for a living, how they or you know, their sexual history, all of those things can really influence the epidemiology for things that are associated with dyspnea. And, you know, just like you would take, you know, the differential diagnosis of dyspnea changes vastly whether or not somebody has an immune system, for example. So I think there's hopefully going to be some nuggets in the social history, maybe even the family history on what's going on here. But the only other point to remark on is that this guy, this is like what we salivate for in internal medicine, right? It's a young person coming in with a brand new sort of syndrome, which I often, as I'm working with learners, I often am like myself struggling between parsimony and complexity, right? You always want to lump before you try to split. And I find that with young people without a lot of medical history or medications, there's less noise in the case and a lot more signal, which makes parsimony an appealing thing as we're trying to tackle this clinical problem, right? So we're going to try to think of one thing as opposed to multiple separate and simultaneous explanations for what's coming.
So going for the family history, he denied any family history, and he's what he works and his social, I don't have, I'm sorry.
Okay, no worries.
So going for the vitals, the patient presents with the temperature of 36.7, the blood pressure 110 for 68, a heart rate of 101, a respiratory rate of 24, saturation of 86 on room air, and then with nasal cannula 6 liter was 95%. The patient going for the cardiovascular was loud P2, 2 of 6, systolic murmur best at the left lower sternal border, a JVP elevated to 14 centimeter, pulmonary diffuse bilateral coarse crackles, and extremities, he was bilateral 1+ pitting edema to the knee.
Okay.
And yeah, the rest was normal.
This is, I want to just be very explicit that when I get excited about symptoms, findings, this is like very clear that I want to be, that this is a person that's suffering, and I don't want to seem like I'm like enjoying their suffering, but this is a very telling physical exam, and I get very excited when I kind of start to see findings at the bedside that can very much start to put things into play. But I just want to say that when we say that things are a good case or a crazy good exam or something like that, just to be very mindful that we're talking about a person with a life in the bed there. And so I just want to, before I get too excited and I show my like how happy all of this stuff makes me, I don't want it to be taken the wrong way. So starting in the vitals, because they're vital, he is tachycardic and he is hypoxemic at rest. I'd be interested to know if his heart rate got a little bit better when he got the oxygen. The other thing that happens here is, you know, he got a decent amount of oxygen, and his sat rose a little bit. But if we were seeing maybe a little bit less of a sat rise in the SpO2, we could invoke, maybe start to think about a shunt physiology in somebody like this guy. And then we get into the cardiopulmonary exam. And on auscultation, what is really being described here is the story of elevated pulmonary pressures. And so that loud P2 with a systolic murmur heard at the left lower sternal border, as well as distended neck veins, I really start to think about right-sided heart failure in this case, specifically due to pulmonary hypertension. You know, then you move on to the lungs, and you say, you know, does he have a quiet chest? Does he have a clear chest? I see Dr. Dancel's on here. So just a quick point, for the single most sensitive test in the evaluation of an elevated pulmonary capillary wedge pressure is lung ultrasound. So I often, you know, don't think of crackles or chest x-rays to help me as much as lung ultrasound helps me in determining kind of what really clear lungs are or are not. However, we have sort of an abnormal adventitious breath sound to suggest that maybe this pulmonary hypertension that we're seeing here is is due to a primary pulmonary process. So this certainly makes me think a lot about primary parenchymal lung disease. So this makes me think about ILD or structural lung disease, bronchiectasis, cystic fibrosis, something that's been maybe subclinically silent in an otherwise healthy 42-year-old person that is now starting to manifest with overt right-sided heart failure and pulmonary hypertension. We have the lower extremity edema that's also kind of contributing here. So if you were to hear quiet lungs, quiet chest, sonographically sort of no evidence of sort of airspace disease, this is a great story for sort of like something that manifests primarily with pulmonary hypertension, sort of the precapillary pulmonary hypertension. The only other thing to mention is that he's a 42-year-old guy. He's actually young enough to have congenital heart disease that's starting to manifest symptomatically in this case. So that's the other thing, is that are those crackles actually sort of from biventricular heart failure, is one of the things that I'm kind of mulling over in my head. As we move forward, I'm certainly going to want an electrocardiogram. We're certainly going to want a chest X-ray, but given how much pulmonary hypertension he has and how he has diffuse kind of coarse crackles, I think that a CT of the chest with pulmonary angiogram protocol is probably also in his future. But as we hear about the labs, the hemogram, if it shows us polycythemia, it can actually tell us a lot about the chronicity of this hypoxemia. And then the other thing to think about in somebody who's tachypnic, which he is that we may actually see like a little bit of a low bicarbonate as a compensation for a chronic respiratory alkalosis, which is what these folks often have. We're going to want to look obviously for renal dysfunction, for liver disease, some other things that could tip us off as to the etiology of what's going on.
Wow, Dr. Restrepo, that was just so good how you dissected all these informations and localized it to more of a right-sided heart problem, maybe due to a primary lung disorder. I was wondering, when we were talking about pulmonary hypertension, would you like just maybe summarize in 1 or 2 minutes the most common causes of pulmonary hypertension? And you already talked about a little bit about the evaluation, but what would be your next tests and which types of pulmonary hypertension there are?
Certainly, Sammy. So there's 5 classes. They are notoriously difficult to remember. It's the WHO criteria. I have a really, really bad way of remembering it. It's like cringeworthy, which sometimes helps people to remember things. But whenever in medicine you have something that's primary, it means idiopathic. It means we have no idea. So 1 is we have no idea, right? So that's people that have kind of genetic causes of pulmonary hypertension, or people that have true pulmonary arterial hypertension. So something that clamps down the pulmonary arteries. This is things like liver disease, HIV, methamphetamine use, all of the connective tissue diseases, that kind of falls into group 1. Then I think about you having 2 ventricles. So group 2 is things that is basically pulmonary hypertension that's caused by left-sided heart disease. All right, they get worse, so don't worry. And this would, epidemiologically, this is probably the most common cause of pulmonary hypertension. Then group 3, the right lung has 3 lobes. I'm telling you, this is really bad. And then, so this is pulmonary hypertension secondary to hypoxic vasoconstriction in the setting of primary lung disorders. This is ILD, bronchiectasis, very bad COPD, but also including OSA in this case. Then group 4, your pulmonary artery kind of branches into 4 different branches that can have clots in them. So this is what's called chronic thromboembolic pulmonary hypertension, which is CTEPH. And lastly is group 5, which is a bit of a wastebasket of diagnoses, sort of like stuff getting, the pulmonary vascular getting squished by a tumor and sarcoidosis and a bunch of other things that I'm not going to get into. So again, the epi, right? Common things are common. Group 2 and group 3 are probably the most common things that you will end up seeing. Worth noting is that congenital heart disease somehow makes it into group 1, but that's just, I think, a different, that's just splitting hairs. I am still kind of worried that this guy could have congenital heart disease, but I'm also kicking around sort of primary parenchymal lung disease as a manifesting with right-sided heart failure at this point. So.
Thank you so much. That is an amazing mnemonic, really. I always had a hard time remembering the 5 classes, but now I certainly won't forget them. So thank you for that. All right, Deborah, please give us more.
So going for the lab. Sorry, the hemoglobin was 17.8.
There you go.
White blood cells were normal, platelets were normal, the metabolic panel was normal, the liver function was normal, and the B-type natriuretic peptide was 1,200. Troponin was negative. I'm waiting for the whiteboard. And going for the image, the chest X-ray, it has diffuse patch opacities, curly B lines, and right-sided fusion. And then the echocardiogram.
Actually, can we pause before we jump into the echo?
Yes.
There's a lot there. So, in my mind, the question is, what side of the heart is that BNP coming from, right? Or is it both, right? Who's stretching out? Is it the right side of the heart or the left side of the heart? Or again, is it both? Diffuse patchy opacities seems like a weird way to call pulmonary edema. And then curly B lines themselves, are associated with kind of thickened interlobular septae and things like that. The one-sided nature of the effusion, while it is possible to have from left-sided heart disease, seems a little strange that it is just on the right side, which again could make you think of lung disease as opposed to heart disease that's causing this. So overall, this still is a great question that I have in my mind. Is this all lung disease that's triggered right-sided heart disease? Is this all left-sided heart disease? This is, I think, a really, really great case to kind of tackle these issues. And then the other thing is, like, is there a shunt, and is this actually like a mixed picture, where you could have many things at once kind of happening? And so, Sammy, to your question earlier, if we're suspicious of pulmonary hypertension as a diagnosis because of, let's just say, exertional dyspnea or the right epidemiology or signs of right-sided heart failure or signs of elevated pulmonary pressures, a transthoracic echocardiogram is the diagnostic test of choice. However, just to note that the real only way to actually diagnose PH is with a right heart catheter. So echo can give you suggestion that the pulmonary pressures are elevated, and it is a non-invasive first step to investigate, but it is not diagnostic. And what we'll be looking for on the echo would be signs that the right-sided pressures are high by way of the right ventricular systolic pressure, or also known as the pulmonary artery systolic pressure, depending on who reads your echo. You want to look for RV dilation to see kind of how is that right ventricle accommodating the pressure. You want to look for the thickness of the right ventricle to see if there's RVH, which can certainly tell you about the chronicity. And then if you want to look for right atrial dilation as well as obviously valves and signs of left-sided heart disease. And I will hope that two things, that this was a bubble study to maybe potentially detect any intracardiac or intrapulmonary shunts at the same time.
Thank you. I had some questions, but you answered all of them. So Deborah, please give us more.
Okay, and the echocardiogram showed a normal left ventricle size and function, no diastolic dysfunction, and the right ventricle was dilated with severe reduced function. The CT test showed no pulmonary emboli, and enlarged pulmonary artery, septal thickening, diffuse ground glass opacities, and right small diffusion.
So it looks, and the valves were all okay, Deborah?
Yeah.
And no bubble study and no shunting anywhere that they saw like an atrial septal defect or a ventricular septal defect?
The right heart catheterization, no.
So we're gonna get to the right heart catheterization.
Yeah.
But let's just pause here and talk about, you know, your eyes are going to get called to the heart, right? That right ventricle is unhappy, right? You have high pressures, you have an enlarged pulmonary artery, and then the left side of the heart looks pretty benign, right? And in a 42-year-old guy, it should be, right? And so it makes me think a lot less that this is due to left-sided heart disease. Again, the bubble study would have been great to have known that, but outside of that, I'm just gonna put the left-sided stuff to rest for now. I do want to then your eyes need to gravitate to what's happening in the parenchyma, right? And what's happening in the parenchyma looks like heart failure, right? So when you see looks like left-sided heart failure. And when you see diffuse ground glass opacities and interlobular septal thickening, that's like, it buzzes in your head, system one reasoning, this is heart failure, right? But he probably doesn't have left-sided heart failure. And when you're dealing with a diagnosis that kind of everything seems to point a little bit towards left-sided heart failure, but there's really no left-sided heart failure or no reason to have left-sided heart failure, there's an entity that we actually haven't discussed that needs to come onto the differential diagnosis, which is called pulmonary veno-occlusive disease. And it's basically sort of obliteration of the venules of the capillaries that basically cause technically post-capillary pulmonary hypertension. It fills up alveoli with water, and it looks in the lungs like there's heart failure, and the right side of the heart is upset like there's left-sided heart failure, but the left side of the heart looks totally cool. And the only way to actually sort this out is with a right heart cath. And when the right heart cath goes in, they're basically going to take that catheter, measure the pressure in the RA, measure the pressure in the RV, go into the pulmonary artery, and then take it, basically fill up a balloon and occlude the pulmonary artery so that they can measure the pressure on both sides, on the mean pulmonary artery pressure side, and they can occlude all of the flow of the blood downstream from that balloon so that there's a static column of blood between on the other side of the balloon, on the pulmonary venous side of circulation. Then you can measure a pulmonary capillary wedge pressure, which is sort of our best guess of what a left atrial pressure is, and thus what a left ventricular and diastolic pressure is, which is preload. And so if he had left-sided heart failure, we would expect that pulmonary capillary wedge pressure to be really high. And the tip off here, and the key to really take left-sided heart failure off of the table in folks with pulmonary hypertension is that pulmonary capillary wedge pressure, so that you can calculate the voltage drop over that pulmonary capillary from the PA side to the pulmonary venous side. And that what we're looking for here is basically trying to rule out post-capillary pulmonary hypertension, which is group 2 PH from left-sided heart.
Wow, thank you. That was just such a great overview over what the next steps will be. I have just a question. When you see diffuse ground glass opacities, we talked a lot about heart failure and being fluid in the alveoli. Do you have any other differentials or things you think about when you see that?
So ground glass is one of these like horrifically non-specific things that you're going to see with CTs, but I think of it as anything, and I think somebody just put it in the differential, but in the discussion, but it's basically, it's an alveolar filling process. And so anything that fills alveoli can, and also just collapsed alveoli or fibrosed alveoli can give you ground glass. So water, blood, eosinophils, lymphocytes, pus, all of that can give you the ground glass opacity. When you add in kind of septal thickening around that, you got to think about things like heart failure again, but you also want to think about different kinds of ILD that we don't necessarily have to get into. And then pulmonary alveolar proteinosis and a bunch of other stuff. So just because I said it, that was where my brain went, doesn't mean that there's not like a litany of other things that cause it. And as I said, I think a primary lung disorder with group 3 pulmonary hypertension is very much still in play. But I do think that my ears go off of like this, the chest looks like there's left-sided heart failure, but he has, the echo doesn't, and he has otherwise no reason to have left-sided heart failure. So I would jump, I think, up next to probably the right heart cath, because that's really what we're gonna have to do as a next step in getting a diagnosis.
Thank you. That was great explanation. Deborah.
So going for the right heart catheterization, the mean pulmonary pressure was 58. And the edge pressure was 10.
The wedge pressure was 10?
Yeah. And after the vasoreactivity test with IV ibuprofen, the patient developed dyspnea and worsened pulmonary edema requiring intubation.
Okay. Is there anything else? So, or we can pause there because there's already a lot. Okay. So if you guys remember, earlier I said the only way you diagnose PH is with the right heart catheter. So when I trained, a mean PA pressure of 25 was diagnostic of pulmonary hypertension. We've actually since dropped it down to 20. So a mean PA pressure of 20 is pulmonary hypertension. His is like over 2, almost 3 times that, right? So he has very high mean pulmonary artery pressure and he has a completely normal wedge pressure. So if you think about that balloon, there's a large pressure drop across the pulmonary capillary, right? And so this would suggest that he has pre-capillary pulmonary hypertension. And what happened is that he got a vasodilator, right? So his artery is dilated. And if you had a pure group 1 kind of process where the problem is in the pulmonary arteriole, then you should get better, right? The pressure should drop. But what ended up happening is that they opened up that capillary even more and there was more flow. And there was something that hit basically a wall on the other side of the pulmonary capillary, which is in the venule. And all that water and all that pressure had only one way to go. So it went right into the alveoli. This is what happens when you give people, with left-sided heart failure, pulmonary vasodilators, but this can also happen again in people with pulmonary veno-occlusive disease. So I'm still worried about this. And I think it'd be really useful to see what those actual ground glass opacities are and what those thickened interlobular septi are. And this is the case when obviously I would be calling a lung doctor to see if we could get a lung biopsy, because that's how you would make this diagnosis. Because, you know, he has low pressure on the left, but he behaves like he has low pressure on the left, like he has high pressure on the left. And his lungs look like he has high pressure on the left. And I'm just worried about pulmonary veno-occlusive disease in this case. Or again, another cause of ILD, meaning that ground glass that was in those lungs and those interlobular septal thickening stuff, that is again a primary parenchymal process that's caused right-sided heart failure in PH.
Wow, I've never heard such a good explanation regarding pulmonary hypertension and breaking it down, and it makes so much sense with the wall when you vasodilate the precapillaries. I was just wondering, you talked a lot about pulmonary veno-occlusive disease, and what would be causing that? And you talked about getting a lung biopsy. That's really not something I think a lot of us are aware about.
To my understanding, I don't actually entirely know what causes pulmonary venous occlusive disease. There are like post bone marrow transplant causes of it, but in somebody like this, I think our understanding is it's largely idiopathic, but maybe somebody, I think it's a short Google away, and maybe somebody can look into it. But at this point in time, we have to figure out if the CT itself doesn't have a perfect pattern of interstitial lung disease, like it's not screaming NSIP, non-specific interstitial pneumonia, or it's not screaming UIP, which is usual interstitial pneumonia. You start having to characterize what the heck's going on in this guy's lungs, and is it in the capillaries or is it in the actual parenchyma? And that's when we think about needing a lung biopsy now that we have the right heart cath.
Thank you. Okay, Madalena, is this gonna be the last aliquot? Okay. Yeah, please take us home.
So he did a lung biopsy that showed widespread fibrosis, intimal thickening, and fibrosis of the small pulmonary veins and vanulas, and interstitial pulmonary edema. And the case resolution was exactly what the Dr. Restrepo said, that was a severe pulmonary hypertension secondary to pulmonary venous occlusion disease. And we are talking about the causes. The causes that we have, it's like genetic mutations, like autoimmune disease, could be scleroderma, lupus, myxedema connection, and can be a toxin exposures like phenylfluramine that implicate to develop. And this patient, after aggressive diuresis, the patient was extubated by his hypoxia and dyspnea, and he improved his clinical, but he probably eventually will require a lung transplant. So great discussion, and I think I learned a lot about pulmonary hypertension, and yeah, thank you so much.
Wow. Sorry, go ahead.
No, so as kind of reflecting about the case, I was a senior resident in the emergency department, and a woman about this age came in with cyanotic and hypoxemic, and she had a lot of really interesting cardiac findings, all of which this patient had. She also had a diastolic murmur that I kind of lulled me into thinking that this was a first manifestation of structural heart disease and of congenital heart disease, and it ended up being PVOD. And so as we talk about kind of recognizing patterns, it's always important to obviously question those patterns and remember epi, because this is an incredibly rare disease, and like the next 30 times or 300 times that you see interlobular septal thickening and pulmonary hypertension, it's probably going to be heart failure that does it. But these associations are so powerful, and it kind of helps you pick out a diagnosis in a lineup if it starts kind of pinging in illness scripts that you have stored in your mind. And so those of you will kind of start to create an illness script from hearing about cases and seeing them and stuff like that. And so it is still a very powerful tool, one that is very susceptible to cognitive biases, but like every once in a while, it's about kind of just picking something out of a lineup that rings true with a particularly impactful case that you saw before.
Wow, my mind is blown. Thank you so much for this amazing case, Deborah and Dr. Restrepo, for even a better discussion. And there were so many teaching points in there, and I think we all learned so much. One thing I wanted to ask, so you said you recognized a certain pattern. Would you maybe like go over that again? What really made you think about that? And yeah.
Totally. It was profound right-sided heart failure with lungs that looked like left-sided heart failure, with no reason to have left-sided heart failure, and an echo that didn't suggest it. That was kind of like, if I boiled it down to a problem representation, this is a 42-year-old guy with no antecedent medical history whatsoever, presenting with progressive exertional dyspnea and hypoxemia, with right-sided heart failure, as well as diffuse parenchymal lung disease consistent with that could be suggestive of heart failure. That illness script to me is, again, 99,000 times heart failure, but in somebody with a normal echo and in somebody with no reason to have left-sided heart failure, that is the illness script of PVOD.
Amazing, makes total sense. I found it just difficult to differentiate it, for example, from an ILD-like process. I know you talked about NSIP, UIP, and that we would have maybe had more clues about that in the CT. So that made you go away from this diagnosis?
Yeah, certainly. And the other thing, and you could, this, like I said, this could very well still be ILD, right? This could still be a chronic inflammatory pneumonia of some sort. This could causing pulmonary hypertension. Usually those people have had ILD or structural lung disease like CF or bronchiectasis. They've had it for years, decades before they develop pulmonary hypertension. The fact that he came in with pulmonary hypertension was the other tip off there, that he didn't have like a long history of really bad, symptoms of ILD, coughing, clubbing, those fatigue, all that other stuff. That was another tip off there. And what really nailed it was the vasodilator challenge, because folks with pulmonary hypertension from lung disease will have drops in their pulmonary vascular resistance and have drops in their pulmonary pressures when you give them that vasodilator, because you're really relaxing that arteriole. And he had a venular problem. He had something on the other side of the capillary.
Wow, that makes just so much sense how you explain it. Thank you so much again. I'm just checking if there are any questions in the chat. No, okay. So I just want to thank you all, and especially the people that donated for the fund. We reached $510. That is so amazing during this session. I think people got fired up due to that amazing discussion by Dr. Restrepo. So thank you so much for that. And really thank you for taking your time and coming to join us. And thanks everyone for donating. And those who haven't yet, please consider donating. It's really for a good cause. Maybe I would give the mic to Maria before giving it to Mukund.
No, thank you so much. We've reached 510 and it's only the first day. So we're off to a good start. Thank you, Dr. Restrepo and Deborah and Sammy. I'm pretty sure you sharing a little bit of your time and wisdom with everybody has inspired others to share a little bit of money with the fundraiser. Please remember that any donation matters, and if you're not in a place to donate, also raising awareness, sharing it on Twitter, on social media, sharing good thoughts into the world is always very appreciated, especially on VMR. So thank you so much. Mukund, you can go ahead and do teaching points now.
Sure. Hello, everybody. We'll go through some teaching points. It was a really awesome case. We started out by talking about 3 primary causes of dyspnea that you should rule out before thinking about more rare causes. So heart disease, lung disease, or anemia. And given this patient's presentation, especially with this dry cough, we didn't think anemia was a prominent cause. We were focused more on the heart disease and the lung disease, keeping in mind that pulmonary edema, maybe due to left heart failure, can cause a cough, so that should still be on the differential. But we did narrow our schema pretty rapidly to emphasize pulmonary hypertension, as evidenced by some physical exam findings, the loud P2 and the left lower sternal border systolic murmur that could indicate signs of right heart failure. And the crackles that were seen on the lung exam indicate that the pulmonary hypertension may be of a parenchymal etiology, so interstitial lung disease, bronchiectasis, so on and so forth. We had a great discussion of pulmonary hypertension and its 5 classifications per WHO criteria, with 1 being arterial hypertension or precapillary hypertension, 2 being caused by left heart disease as the most common cause, 3 being caused by primary lung disorders leading to hypoxia and local vasoconstriction, 4 a chronic thromboembolic pulmonary hypertension, and 5, all sorts of other causes. We learned that the definitive diagnostic tool for pulmonary hypertension is right heart catheterization. Although you may be able to gain some non-invasive clues using an echocardiogram, such as signs of right heart dilation or right ventricular hypertrophy, all the way up to right atrial dilation, and measurement of some right ventricle systolic pressures. We had this really fascinating way of determining pre or post-capillary pulmonary hypertension using a vasodilator challenge, in which prostaglandin analog is given to dilate the arterioles. In this patient, it made his dyspnea worse, which indicates that the dilation of the arteries leading to increased blood flow through those arteries is coming up against a post-capillary obstruction. In this case, we are more likely to think of a pulmonary venous cause. And we settled in the end on pulmonary veno-occlusive disease, which is a really fascinating new diagnosis to me, an obstruction of the small pulmonary veins by a fibrosis of the venous intimal layer. And that's causing increased pulmonary venous pressure and resistance, and is a rare subtype of the post-capillary family of pulmonary hypertension, in which the echo shows signs of right heart failure, as seen with this patient, but where the chest X-ray mimics left heart failure, as seen by the variety of chest X-ray findings here. So thanks all. This was a really fun case and lots of learning for me.
And Mukund, may I just one like quick just to refine the bit about the vasodilator challenge. So we determined pre versus post capillary by the drop, the degree of drop in the mean from the mean PA to the pulmonary capillary wedge pressure. That's a number that's actually called the transpulmonary gradient. And so if you have a very low transpulmonary gradient, that just means that the left-sided pressures are high, and that's post-capillary hypertension. But if you have a big drop from the PA side to the PV side, to the pulmonary vein side, or the wedge, that's pre-capillary pulmonary hypertension. The vasodilator challenge further just is prognostic and therapeutic, because it can tell you whether you have primary a primary group 1 pre-capillary pulmonary hypertension, and it can give you therapeutic options because you can use vasodilators in those folks, but you can use them also in group 3. So the pre and post is done basically with that by subtracting the wedge pressure from the mean pulmonary artery pressure.
Well, thank you all so much. And thanks again, Dr. Restrepo, and for emphasizing all this teaching. That was just a masterclass of a clinical reasoning exercise. And I think we all enjoyed it so much and had a good time. And thanks everyone for donating. And I hope you all have a great rest of your day. And see you tomorrow. And thanks again for donating. And yeah, take care. Bye, everyone.
Thanks for having me.